all who have joined here. Dr. Shimmi, President IAP Kerala, Dr. Jose, immediate past President, Dr. Darli Mohammed, who is the HOD Pediatrics GMC Kottayam, Dr. Gigi, who is the mentor of today's program, Dr. Parvati, who is the lead discussant for today, Virendra Kumar sir, and all the seniors and also the postgraduate students and friends. So I would like to welcome Darling Madam to say a few words and also to introduce the speaker.
Good evening, all. Respected President Dr. Shimmi, immediate past President Dr. Jose, PG Club Coordinator Dr. Mohandas Nair, Kottayam Coordinator Dr. Thomas Varghese, today's mentor Gigi, Dr. Gigi, today's presenter Dr. Venki Venkateswaran, and all the others who have joined this platform. And joining from the northern side. And this is the first episode of PG Club from Kottayam. And we have selected a case that is from the endocrinology. And Dr. Venkateswaran will be presenting. And Dr. Parvati will be the lead discussant. She is a consultant pediatric endocrinologist from Master Medcity of Kochi. She did her MBBS, DCH and MD from Government Medical College, Thiruvananthapuram, and had taken the fellowship in pediatric and adolescent endocrinology from the Indira Gandhi Institute of Childcare, Bangalore. And she's known to almost everyone in this group. And I welcome Dr. Parvati, and over to you to lead the program. Thank you. All the best to the presenter and also for the mentor. Thank you.
Thank you. Thank you so much, madam, for the introduction. Good evening, all. Thank you for this opportunity to take a PG class on an infant with endocrine condition. So I think without much ado, I can ask Dr. Venkateswaran, who has prepared very well on this infant, to take us through the story of this infant. I think if all agree, we can start with the presentation. Dr. Venkateswaran.
Thank you, ma'am. Good evening to everyone. Thank you for this opportunity for me to present this case to the great teachers here. So I'll be presenting a case, a 4.5 months old child, a male child, date of birth on 10th August 2023, hailing from Kodamangalam, Ernakulam. Informant was mother, reliable history, and date of admission to a facility at 27 December 2023. The chief complaints are complaints of fever for 3 days, complaints of poor feeding for 3 days, complaints of inconsolable cry for 3 days, and complaints of vomiting for 3 days, and the episode of abnormal jerky movement of limbs was the chief complaints. Coming to history of presenting illness, the baby was apparently normal before. The baby had a history of fever for 3 days, which is insidious in onset, low-grade fever, and the fever episodes were intermittent. And the baby had an initial history of decreased feeding time during the feeding, and there is a history of excessive cry while feeding, which eventually following which the baby had a poor feeding and the excessive cry. And during this episode, the baby had multiple episodes of vomiting for the past 3 days, which occur both immediately after feed and also after 20 to 30 minutes after post feed, which is non-bilious, non-projectile vomiting and contain milk and curdled milk.
Dr. Venkateswaran, previous slide, can I ask a few questions?
Yes.
So this is a 4.5-month-old male baby who was previously normal. Could you just give us a few history till the 4 months was the baby gaining weight properly? any hospital visits for
No, ma'am.
any similar
Like
complaints or any?
the baby was apparently normal. Like there is a history of poor weight gain, which was noted at the 3 month. That was during the immunization visit. They have been counseled that the baby had a poor weight gain, and they have started on some food supplements like formula feed supplements. That was a history that was presented before the illness has been started.
So now the baby has presented with fever and poor feeding with vomiting. You
Yes.
can go ahead.
So coming to the history further, there is no history of loose stools or infrequent or no stooling or any abdomen distension. There is no history of cough, nasal discharge or regurgitation of feeds. There is no history of breathing difficulty or fast breathing noted. There is no history of bluish discoloration of limbs or suppressed cycle or sweating while feeding. There is no history of crying during maturation or decreased urine output or unusual order. There is no history of swelling of joints or any decreased limb movements. There is no history of rash or no history of lethargy or no history of trauma.
I think you mentioned the history of poor feeding, right? I think
Yes,
the
ma'am.
lethargy can be omitted there. The baby has
Okay.
poor feeding. An infant doesn't exhibit too much of lethargy. It manifests probably as a poor feeding.
Okay. Then the baby was initially taken to a local hospital at 36 hours of onset of illness, and the mother was informed that the baby had a breathing difficulty and low blood pressure and low oxygen levels, and the baby was taken to ICU facility. And the mother was informed the baby was started on oxygen support and intravenous medications to stabilize the blood pressure. And after that, the mother was informed the baby had a episode of abnormal jerky movements of all limbs at the hospital stay at the day 2 of illness, and they have started on medications to control the further movements. And the baby was referred to ICH on day 3 of illness. Like seminology about the seizures has not been clearly known. And coming to the past history, there is no similar illness in the past. So coming to antenatal history, so this is the second child of non-consanguineous marriage, born to 29-year-old mother and a 39-year-old old father. The blood group was A negative, and anti was taken in the previous pregnancy. Coming to first trimester, UPT was positive after 4 weeks of amenorrhea. Booked case at the private hospital. No history of hyperemesis, fever with rash, bleeding PV. History of UTI was present and had taken oral antibiotics for 5 days. No history of radiation exposure. Folic acid tablets were taken and 2 doses of PT were taken, and dating scan was found to be normal. Coming to second trimester, quickening was felt at 5th month. No history of ma'am.
Sorry, my connection went off. Venkatesh, can you just go to the previous slide? I missed it.
Yes.
Yeah, please go ahead.
Yes, ma'am. The baby was referred to ICH on day 3 of illness. There is no history of similar illness like this presented in the past.
Okay.
Coming to antenatal history, it is a second child of non-consanguineous marriage, born to 29-year-old mother and a 39-year-old father. Blood group was A negative, and anti-D was taken in the previous pregnancy. Coming to first trimester history, UPT was positive after 4 weeks of amenorrhea. It was a booked case at the private hospital. No history of any hyperemesis, fever, rash, bleeding PV. History of UTI was present, and the oral antibiotic was taken for 5 days. And no history of radiation exposure. Folic acid were taken, TT 2 doses were taken, and dating scan was found to be normal. Coming to second trimester history, quickening was felt at 5th month. No history of fever, bleeding PV, no history of gestation diabetes mellitus, gestational hypertension or hypothyroidism. IFA and calcium supplements are taken. Anomaly scan was found to be normal. Coming to third trimester history, the mother can appreciate the fetal movements well. No history of fever, urinary tract infection, bleeding PV or leaking PV, and no history of gestational hypertension, diabetes mellitus or hypothyroidism. And supplements were taken, and growth scan was found to be normal. And during that time, ICT was done, and ICT was found to be positive at 8th month. So they decided for coming to natal history. So at the late preterm, cesarean section was done in view of previous cesarean section, and a positivity of ICT. And it was a male baby right soon after birth. Birth weight was 2.550 kg, and the blood group was O positive. The baby was breastfed immediately. Urine and meconium was passed within 24 hours. No history of respiratory distress or neonatal seizures has been noted during the stay. History of NICU admission for neonatal jaundice, it is RH incompatibility was present for 2 days, and phototherapy was given for 48 hours. And the baby was discharged on postnatal day 5 with a discharge weight of 2.225 kg on breastfeeds.
So Dr. Venkatesh, the birth weight was 2.5,
Yes, ma'am. The birth weight is 2.5.
By 5th postnatal day, the baby lost around 10% of birth weight.
10%.
Am I right? Yeah.
Yes, ma'am. It's around 10.
Yeah, please.
Coming to developmental history, motor development, the partial neck holding was started at 4th month. Social smile at 2 to 3 months, and the baby can recognize mother at 3 months. Cooing at 2 months to 3 months is present. The baby turn head towards the sound, and the baby follows light and fixes near objects like toys. Coming to nutritional history, the baby was breastfed 8 to 9 feeds per day, and each feed time was around 10 to 15 minutes. No letdown reflex was present. Uh, Good sucking has been noted. They have started on formula feed at 3rd months. They give 30 ml per feed 2 to 3 times per day, and there is appropriate dilution. And they have started in view of poor weight gain, and they have introduced ragi at 4th month in the form of thin porridge, one serve per day, which was around 15 to 20 ml. And the baby sleeps well after every feed, and night feeds were present. Urinary frequency was good 10 times per day with this normal color, and stool frequency 2 times per day, which is yellow color. And they provide daily vitamin D also. So coming to immunization, the immunization was done at Chiruvarathur HC. They've taken 0-day vaccination, 6th week vaccination, and during that time the weight was found to be 2.8 kg. And they have taken 10th week vaccination, and the weight was at 3 kg. So they have been counseled to start on formula supplements during that time. And the 14th week vaccination has not been taken, and there is no history of any AEF noted.
Do you want to make any comment on the weight gain by 2.5 months? 10th week, you say the baby's weight was 3 kg. Yeah.
Yeah. At 2.5 months, the weight should actually should increase, but there is a poor weight gain at 2.5 months has been noted.
Okay, so
roughly around.
Yeah, do you want
around 4 to 5 kgs.
Okay. Yeah, go ahead.
Coming to family history, there is a history of hypertension in a maternal grandmother, and the paternal grandfather died due to some malignancy. The history is not properly known. And the first child is a 6-year-old female child, which was born full-term CS, and cried soon after birth with birth weight of 2.45 kg. It was a female child. There's a history of ambiguous genitalia, and the baby was admitted on postnatal day 20 at a facility and found to have some genetic defect, and they started on medication from postnatal day 25, and the baby was and the child was continuing on the same drugs now. There is no family history of seizures or cardiac illness.
Venkatesh, the family history, can you so there is a elder sibling who has presented with an ambiguous genitalia, right?
Yes, ma'am. Yes, ma'am.
Okay, and has been started. So that is a quite a relevant history when a baby presents at or in infancy with the features with poor feeding, vomiting, and all. Okay. Any other family history of newborn or infant deaths?
No, ma'am. No history of any newborn death in their family, like in the cousins or in what.
Fine. Go ahead.
Coming to socioeconomic history, the father is 39 years old, studied up to high secondary. He runs his own business. Mother is 29 years old, studied MCOM, is a homemaker. He belongs to lower middle class family according to modified Coupon scale 2023. It's a Pakka
Correct.
house, separate kitchen and sanitary latrine is present. No overcrowding, no passive smoking, pets or firewood smoke. Waters from home well, which has been used as well. So coming on a short note on treatment history, which was done at the referring hospital, the baby was presented in features of shock and they have given fluid boluses and dopamine infusion was started and in view of seizures, they have been started on levetiracetam and the baby has been referred there. So coming to general examination, the child is alert, pale plus, pedal edema is plus, no ictus, no cyanosis or no lymphadenopathy. Pulse rate is 168 per minute, regular rhythm, normal.
There is there you have mentioned there is pedal edema, right? Previous
Yes,
slide.
yes, ma'am.
Okay. It's very unusual for an infant to have a pedal edema, right?
Like
Was there
it was
any?
such a ankle. It was such a like
Okay.
it was an ankle edema.
Okay.
It does no cyanosis or no lymphadenopathy. Pulse rate is 168 per minute, regular rhythm, a regular normal volume, peripheral pulse is palpable and no radiofemoral delays. Blood pressure, it is 86 per 42 millimeters of mercury. It is less than fifth percentile in the left upper arm in supine position. CR, capital refill time is less than 2 seconds. Respiratory rate is 34 per minute. Temperature is 101.7 degree Fahrenheit and SpO2 is 100% in room. So coming to head to foot examination, head appears normal in size and shape. Anterior fontanel is depressed of size of 2.2 to 2.2 centimeter. Eyes were sunken. Ears are normal. No facial disformation noted. Oral cavity is moist. Chest and abdomen, no deformity is there. BCG scar present. Skin pinch goes slowly. And limbs, no deformity. Male external genitalia present with bilateral testis and spine, no deformity is noted. So coming to anthropometry, the corrected gestation age was around 3.5 months. Weight for age observed is 3.1, expected is 6.5 kg, which is less than -3 standard deviation to severe underweight. Length for age is 57 centimeter, expected is 61 centimeter, inference is -3 st, severe stunting, and weight for length is at less than -3 st, severe wasting is present. Age circumference observed is 37.6, expected is 40.5 centimeter, and the inference is -2 to -3 st.
So do we have a growth
Yes,
chart
growth
plotting?
charts.
Yeah.
This is the weight for age chart, which was at the which was below the -3 standard deviation. This is the length for age chart, which is at below the -3 standard deviation.
Okay.
And this is the weight for length chart below the -3 standard deviation. It's a age circumference chart between -2 to -3 standard deviation. So coming to system examination, examination of respiratory system. Respiratory rate is 34 per minute. Bilateral symmetrical
This
chest
baby
movements.
presented with fever, poor feeding,
Poor feeding.
vomiting. So it would be better if we look at the GIT first. That's
Yes.
what I think.
So examination of abdomen. Perabdomen umbilicus is inverted, no visible scar and no visible veins. Perabdomen is soft, no mass palpable. Liver just 1 centimeter palpable below the right costal margin, and liver span is 4.5 centimeter. Spleen not palpable and no free fluid was known.
I think in the examination of abdomen also, you can mention the hernial orifices and the genitalia can be mentioned along with that.
Yes.
Okay. If you have mentioned elsewhere, it is fine. You can go to finish the other systems and come to that.
Okay. So examination of respiratory system. Respiratory is 34 per minute. Bilateral symmetrical chest movements present. No retractions. Bilateral air entry is present. And normal vesicular bed sounds here equally on both
I
sides.
think it's very important to go by the history rather than go by the diagnosis.
Okay.
So I would prefer GIT. Then you mentioned the baby had a fever, lethargy, and seizures. Am I right?
Yes, yes ma'am. Yes.
Okay, so neurology. So always go by the format. That would be helpful.
Okay. Coming to examination of central nervous system. Tritone is normal and baby is alert. Coming to cranial examination, bilateral pupil is equally reactive to light. No facial asymmetry is noted, or no the baby is allowed to sounds, and no regurgitation of feeds and baby swallows with. And motor exam, posture, the child is lying in supine with some flexion of elbow and hip and knees. And tone, normal in all limbs. Power is not to be 3 by 5 in all limbs, and reflexes is 2 plus in all limbs. Spine is 1 to be normal.
Okay.
So coming to examination of cardiovascular system, a heart rate is 168 per minute, no precordial bulge or visible pulsation noted. Apex with the fourth intercostal space of the mid-clavicular line, no palpable thrill or parasternal heave. S1, S2 heard normally. Grade 2, a short ejection systolic murmur is heard at the left second intercostal space of the lateral sternum border. And examination of respiratory system, as already mentioned, normal vesicular bed sounds is best.
Please go ahead.
So coming to examination of external genitalia, is a male external genitalia, bilateral testis palpable, no hyperpigmentation is present, stitch pineal length is found to be 4.3 centimeter, and testicular volume measuring with the archimetric was 1 ml in both sides. So these are the graph which was mentioned in the Indian studies, Indian standard, which was found to be in the normal zero standard deviation of this particular age.
Okay. Have you finished the exam? Okay. Okay. I need to hear your summary, and then from your detailed history taking and clinical examination, what are the DDs you would like to think of at this point?
Okay. It's a 4.5 months old baby born by late preterm. The birth weight of 2.5 kg, had an NICU admission for neonatal hyperbilirubinemia for the incompatibility. Partially immunized with complaints of fever, poor feeding, inconsolable cry, and vomiting for 3 days, with a history of abnormal jerky movements of limbs. The family history of first sibling with the history of ambiguous genitalia. On examination, pallor press, ankle edema is present, febrile, eyes sunken, skin pinch goes slow, with the signs
Not
of
sure whether
dehydration.
you looked for any presacral edema, because when you have an ankle edema, you need to, because the baby is in supine position, I think that also should be mentioned. Okay, and you have taken a good negative cardiac history, right?
Yes, sir.
Okay.
With the poor weight gain and severely malnourished, with grade 2 ejection systolic murmur present in the left lateral upper sternal border and no organomegaly. So coming to differential diagnosis, the differential of this which I could go with sepsis or septic shock, meningitis or failure to thrive, acute metabolic decompensation, maybe in donor of metabolism, or adrenal crisis.
Okay, so this is a 4.5-month-old baby who just had a failure to gain weight with no other symptoms, who has now presented with fever, poor feeding, vomiting, and 1 episode of GTCS.
Yes.
Right?
Yes.
Okay, so in order of possibility, and I think based on the commonness of presentation, okay, you would like to consider sepsis, I agree. And also with the clinical presentation, you would like to consider central nervous system infection, meningitis. Okay, anything else? You mentioned about an acute metabolic decompensation. So there are many primary conditions which could present with an acute metabolic decompensation. Is there any condition where you can have electrolyte abnormalities, a surgical condition which can present with persistent vomiting? So the once you get a good history and after your clinical examination in the ED or the OPD, as a pediatrician, you need to formulate certain differential diagnosis. Then only we can go further and evaluate and give a proper treatment for the infant, right? So, any other surgical illness which can present like this?
Maybe pyloric stenosis.
Yeah, Ruby has answered hypertrophic pyloric stenosis. Okay. So, sepsis, meningitis, and acute GE. You mentioned an early complementary feeding, right? By 4 months, the baby was started on raggy feeds, diluted or so. Okay, so you have to think of an acute gastroenteritis, a primary surgical condition which is manifesting with an acute metabolic decompensation. And yeah, failure to thrive cannot be put as a diagnosis here. We are looking at the etiological diagnosis possible, so that can be removed. Metabolic decompensation, I agree, due to several primary conditions, just like a surgical condition. Or you mentioned the elder sibling, which is a very significant history. But these two kids are products of non-consanguineous marriage, right?
So, non-consanguineous marriage.
Are parents distant relatives by any chance?
No, ma'am. I have
No.
inquired. They said there's no relations between the two families. And like as per mother, they said no. Like they do not know the history about the father
Okay.
and all. They have like they
So
are
at this point,
non-consanguineous.
looking at the DD is very important, because an infant who is presenting with a dyselectrolytemia, vomiting, lethargy, it is a very common condition. So it's very important to understand what is the basic pathology. Getting a good history and thinking about the DD is very important, rather than the getting to the right, going by the diagnosis of this case. So analyzing the history is very important. So we mentioned about sepsis, gastroenteritis, pyloric stenosis, or any other surgical conditions. Okay, adrenal insufficiency, I agree. It could be a congenital adrenal hyperplasia. Any other condition in infancy which can present, the baby would be having fever, poor feeding, lethargy, vomiting with dyselectrolytemia. And okay, dyselectrolytemia could produce the seizures, and the baby has a similar presentation. The fever and the baby has a cloudy urine.
UTI, that in this age, urinary tract infection.
I can't hear you.
Urinary tract infection.
Yeah, UTI, I agree.
And
R.
R.
How does it produce dyselectrolytemia? So I am sorry, my video is not working. There's something wrong with my laptop. I hope you can hear me clearly. UTI, how does it produce a dyselectrolytemia? Similar to this, similar to your case.
In UTI patients, there will be a history of vomiting, and they may be.
The clinical presentation would be similar. Suppose the same, a male baby has come to you with fever, poor feeding, vomiting, and the mother luckily gave you a history of cloudy urine, and you check the urine is full of pustules, you have sent for culture. And similarly, you have a dyselectrolytemia, hyponatremia, hyperkalemia. What would you think of? It is not a very rare condition. It is a quite common condition. Yearly, we might get 2 or 3 cases, and this differential diagnosis should be definitely thought of to provide appropriate treatment and avoid unnecessary treatment. Okay, so there is a condition called pseudo-hypoaldosteronism, which could similarly present. So it could have dyselectrolytemia, hyponatremia. So the basic pathology is aldosterone resistance, renal tubular aldosterone resistance, which is caused because of the some of the acute phase reactants that is produced during the UTA, which can cause a transient aldosterone resistance and present just like congenital adrenal hyperplasia. So it is very common. So you need to be aware of this condition. So these are the differential diagnoses you would think of at this point. Okay. Mohandas had asked a question whether screening was done for newborn screening was.
Yes, ma'am. I have inquired, but they didn't have the evidence for that. When I inquired, they said newborn screening was done. It was found to be normal.
Was the baby born in a government hospital or a?
No, ma'am. It was done. It was done at the private sector, ma'am.
Pardon me?
It was at the private hospital.
Okay. 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 Please go ahead. You can proceed.
So, coming to discussion with the DDs, which has been presented. So initially, baby presented with the complaints of fever.
Also, somewhere I saw you mentioning fever in the negative history. There is no history of chills and rigor. It is always better not to present a chills and rigor in an infant, because usually they have the brown fat. It's a non-shivering. I think you changed it. That's what
I have changed. I have changed.
Fine. Yeah.
So as a possibility, I would go for sepsis or a septic shock based on the history. We have done the sepsis screen, which was found to be negative, and chest X-ray does it show any infiltrate? And the blood culture was found to be sterile, and urine culture was found to be sterile.
We have done a
And
urine and urine culture. So
urine
this
culture.
differential diagnosis should be in your mind. Then only we'll be able to rule out this because, as I mentioned, pseudohypoaldosteronism, I'm sure many of you might have encountered. It is not that rare. It is common, especially in infantile UTI and also more common in male babies. It could present with this where you might mistake it as a congenital adrenal hyperplasia, maybe unnecessary treating with hydrocortisone. So if you are aware of this, it is easy to treat this condition. You treat the UTI and the aldosterone resistance would naturally revert. Okay.
Okay. So we have done a CSF study in view of meningitis, and there is no cells and normal protein, no hypoglycoria was glycorrhea was noted, and CSF culture found to be stable. So coming to that ankle edema, it's maybe due to the nutritional one, but there is no history of GER or improper dilution of formula or pyloric stenosis or any chronic infection.
The edema was bilateral, is it?
Yes, ma'am. It was a bilateral edema. So maybe nutritional. Then we go for a possibility of any inborder of metabolism, and due to the new evidence of a murmur, maybe a congenital heart disease. But there is no history of any such rest cycle or no sweating while feeding. So the echo showed there's a acyanotic heart disease with 3.5 mm OSAST with no other significant major anomaly or no signs of heart failure.
Okay.
So coming to the presentation, the acute presentation may be a clinical manifestation of acute metabolic decompensation, which may include vomiting or anorexia or failure to feed, lethargy that can progress to coma or seizures, rapid deep breathing, and they progress to apnea. It may also have abnormal neurological evaluation. And the blood investigation showed dyselectrolemia and metabolic acidosis. So the further workup has been done. So this was the first one was the investigation which was done at the private hospital at the admission. It was found that sodium is 120 milligrams per liter and potassium is 7.5. There's hyponatremia and hyperkalemia, and metabolic acidosis was present. And there is
So from this preliminary investigation, so looking at the initial investigations, there is anemia, there is a mild thrombocytosis, probably because of as a acute phase reactant, and the major change is the dyselectrolytemia. So you can probably narrow down your differential diagnosis from the what all we made from the initial DDs. So the probably the sepsis meningitis just moves out, and the conditions with dyselectrolytemia comes into place. So the conditions with dyselectrolytemia, which we discussed, were definitely as a pediatrician, the first thing, even though I mentioned about pseudohypoaldosteronism, that should not be the first DD. As a pediatrician, it's very important to think of CAH, congenital adrenal hyperplasia, and adrenal insufficiency, and start treatment without delay, because as you know, it is a life-threatening condition. If it is not identified at first place, we are likely to lose babies, especially male babies who do not have. So male babies, they do not have much of virilization features. Usually, they will have a mild increase in stretch penile length because of the increased testosterone, which is very difficult to diagnose. So usually it will be missed. So before the initiation of this newborn screening, usually we had a lot of unexpected male babies presenting, infant deaths, sudden infant deaths because of CH, because it is undiagnosed. So the DDs now you will think of is congenital adrenal hyperplasia, number one. Number two, again, as I mentioned, pseudohypoaldosteronism still stands good here because the baby had fever, lethargy, vomiting. It could be a UTI causing a pseudohypoaldosteronism. Anything else you want to think of here?
Madam,
would your surgical illness, pyloric stenosis, stand still here?
Hypokalemia, like.
Okay, so usually pyloric stenosis, the classical electrolyte picture. Do you want to mention what is the classical electrolyte abnormality in hypertrophic pyloric stenosis?
Hypokalemia,
Yeah, hyponatremic, hypokalemic, metabolic,
metabolic alkalosis.
metabolic.
Metabolic alkalosis.
I can't hear you. Metabolic alkalosis, you mentioned.
Metabolic alkalosis.
Yeah, metabolic alkalosis with paradoxical aciduria. That is a
Aciduria.
classical presentation of a pyloric stenosis. So that is probably out. And then also congenital hypoaldosteronism, which is very, very rare. That is due to aldosterone synthase deficiency. Okay. So probably these are the differential diagnosis we can think of here. That is all possible with the hyponatremia, hyperkalemia. Yeah. Okay. Please go ahead with the rest of the investigations. Yeah.
So there may be a possibility of RTA, which is typo, which is very rare, like hyperkalemic RTA. We have done like urinary and
Okay.
Typo
Renal
art.
tubular acidosis usually. So, what is a classical symptom of an infant presenting with renal tubular acidosis? Failure to thrive would definitely be there. Other classical clinical history, what will be the findings? Positive history findings. A baby with failure to thrive coming to you when you're taking a history. Considering renal tubular acidosis, what specific history will you ask them on? Two histories, polyuria and polydipsia. Okay, so they are very classical. So did this baby have excessive urine output or excessive?
No.
Okay. So even in congenital adrenal hyperplasia, even though there is a dehydration, do you expect a oliguria? No, actually no. So usually the urine output will be normal or it can be increased. Why? Because there is urinary sodium loss. So there is definitely a normal urine output. Or can you tell me one more condition where the baby would be dehydrated, but there will be no oliguria? Actually, the urine output will be high. Classical condition. If you don't answer this, I'm sure Thomas sir would be irritated. The baby is or the child is dehydrated. So usually in dehydration, there would be very good. Yes. DK, diabetic ketoacidosis. Okay. Whenever you have new cases of diabetes presenting with diabetic ketoacidosis, when you look at the kid, some sensible mothers tell you the baby is dehydrated, but the urine is just pouring out. So dehydration without oliguria. Always check a blood sugar. Okay. So similarly, in congenital adrenal hyperplasia also, you won't get a reduced urine output, even though there would be dehydration. Usually there will be a normal urine output or sometimes increased urine output because of the urinary sodium loss. Okay. Okay. So renal tubular acidosis, usually there will be polyuria, polydipsia, or few electrolyte abnormalities. Okay. Yeah. Go ahead.
So there is a history that a previous child with a history of ambiguous genitalia. So with the
and regarding the electrolyte abnormality, which is more common in a renal tubular acidosis, here we have a hyperkalemia with a potassium of 7. So usually you have in the more common forms of renal tubular acidosis, you have a hypokalemia. And hyperkalemic RTA, usually it is not that common compared to the proximal or the distal.
So with a clinical suspicion of a previous child with a history of ambiguous genitals, so we done a serum 17-hydroxyprogesterone. It's found to be elevated, and the child was during that acute stage, the child was given fluid bolus, and the maintenance fluid has been high, and was started on hydrocortisone at 100 mg per meter square body surface area, and put on maintenance dose, and later we start on fludrocortisone. And also we start on antibiotic coverage to the patient, and has been monitored.
So treatment-wise, definitely when you have such a baby in the casualty, presenting with hyponatremia, hyperkalemia, the impetus would definitely be on treating the baby immediately. But thinking the differential diagnosis would help us further. So with this dyselectrolytemia, what other differential diagnoses are possible, which we have mentioned. So you have started the treatment and the baby improved, right?
Yes, the baby has been thriving well.
The value of 17 OHP, I think I didn't notice. Yeah. Okay.
It was 20 nanogram per milliliter.
Okay. It was more than 20 nanogram.
Yes, ma'am.
Okay. Very much elevated. Yeah. Any other test? Could we do a, this is a male baby, could you do a testosterone or androstenedione?
We can do,
Okay.
but
You mentioned there was no hyperpigmentation, did you?
yes, ma'am. Yes, ma'am. There was no
No
hyperpigmentation.
hyperpigmentation. The
Yes.
baby had a similar skin color as the parents, is it?
Yes, ma'am. Like it was a fair
Okay, it's very
complexion.
important to be watchful because to compare it with the parent's skin color and also specifically look at what are the areas where you will look at for hyperpigmentation. It's very difficult. Suppose, so you know, congenital adrenal hyperplasia is a spectrum of conditions. You could have mild
Yes.
and a severe form. So there is a very huge spectrum. So the clinical presentation could also vary. This baby has presented by 4.5 months, depends on the enzyme deficiencies and the metabolite accumulation. The clinical symptoms would vary. So the hyperpigmentation, even though it would be present, it would be mild. So what are the areas where you would look for hyperpigmentation? So if the baby has a severe form of CAH, definitely you know the uniform or the generalized hyperpigmentation. So otherwise, where would you want to look for?
Over the genitals
Genitals, agree.
and
Nipples and around the umbilicus. Okay. And also the skin creases. Newborn, it would be difficult. So newborn, I think nipples, umbilicus, and the genitals, you can just compare and also compare the skin color with the parents. Okay. Mild hyperpigmentations could be missed. And also male baby, a few of the cases which we had, I've noticed that there would be a mild increase in the stretch penile length if you religiously calculate the stretch penile length compared to the median value of that age, which is because of the increased testosterone. So usually they won't have any ambiguity, but they would have a mild, that is a form of increase, that is a manifestation of increased testosterone activity. Okay.
so this is the current status of the baby. The baby is on breastfeeds and been adjusted calories and started on formula feeds on hydrocortisone of 15 mg per meters per body surface area, fluorocortisone of
How are you giving
four.
the hydrocortisone? How many times daily?
It was given daily dosage, higher doses at the night.
Preferably, you can give it as thrice daily. Yeah. Okay.
The target weight was found
Your
6.
fluorocortisone requirement is quite low, right? The baby is on 20,
Yes.
25 microgram. Am I right?
Yes, ma'am. 25 numbers.
Okay.
The current electrolytes used was sodium is 144, potassium was 4.2, urea was 60, and creatinine of 0.4.
So this is after how many weeks of treatment?
Ma'am, this is about 10 days, you know, after
About
10 for 2 weeks. About
Could you
2
just
weeks.
tell us how is the weight gain and the activity of the baby after initiating treatment?
The current weight was which was check was that it was a 3.8 kgs, and there is a
So there is
fluctuation in
weight gain, right?
weight gain is present, and the baby is quite active. In initial presentation, the baby was well irritable. Now the baby has been taking feeds, and the baby was active. The baby is active and playful during the examination.
Okay. Okay. Yeah.
So this is a case of the firstborn. Just a small brief history on the firstborn. Uh, the first, the firstborn, which is conception at 23 years of age, antenatal UST during the growth scan, they found some uteroplacental insufficiency, and the plan for CS after 36 weeks. And the baby has been admitted here in view of ambiguous genitalia on a postnatal day 20. During the stay, the baby was also found to have hyponatremia and hyperkalemia. UST was done this is corresponding to female ovaries, and 17-hydroxyprogesterone is elevated. The child had the clitoromegaly as ambiguous thing, and just found to have CAH virilizing type of 21 hydroxy deficiency. Karyotyping was done, which showed 46 X's.
Okay, I think, but it's a salt losing type of CH. Probably you have named it wrong. Even though there is virilization, if there is salt losing, you call it as a salt losing, and the other one is called a non-salt losing simple virilizing CH, which is less common compared to the salt losing. Okay, so the elder sibling, female child, it was a 46XX form of DST with
46
virilized
DST.
genitalia, diagnosed at newborn period, right?
Yes, yes.
Okay, okay. And what is the age of the kid now?
Currently, the child.
Could you get any other details
Yes,
of the
so the current
genitalia? Is there any urogenital sinus?
yes, ma'am, minimal examination has been like done.
Okay.
So we had seen clitoromegaly is like a palace thing has been present. Now. So currently the baby is 6 years. It's just like a regular follow-up. Initially they had done a follow-up at year up to 2 years, and mother says the child has been shown in a nearby hospital, and the 17 hydroxy was done before 2 years. Like
I think
no
this
follow-up
family
has
should
been
be
done in
counseled for a
between.
proper follow-up, because
Uh,
even with the elder sibling having this condition, probably they were not aware enough for a screening. I don't know. So basically, and the follow-up also, as you mentioned, is very poor. This baby needs to be under your proper follow-up and evaluation, because younger kids, especially when they have intermittent illness, they are likely to go in for adrenal crisis.
yes.
Okay. Yeah.
So now the baby is on hydrocortisone of 5 mg from interspine of fluorocortisone of 50 microgram. Clitoromegaly is present. Weight is 14 kg at third centile, and the height is at 109.57 at 25th centile. Bone age is found to be around 6.5 to 7 years, and it has been reared as a female.
Yes, Venkatesh, you can go ahead and yeah,
Yes,
that's it.
that's it.
Okay, so for your case, this 4.5-month-old male baby who has presented with these particular complaints and dyselectrolytemia. So at this point, could you give me a complete diagnosis, and how would you manage and how would you counsel this family? After that, we'll go to a short discussion if time permits. Yeah.
So
How
this is a
is
case of
Venkatesh going to manage this family? How are you going to counsel them? Because the elder sibling is also probably not under proper follow-up. They are on irregular follow-up. So how would you counsel this family and plan the
now
follow-up?
like based on the disease type, now the child has to be the parents has to be counseled on the complaints of the drug, and they should not skip the drug.
Okay,
That
so you
should
have
be
already
advised.
started the baby on hydrocortisone and
Yes,
fluoricot, and the electrolytes are normal. So they need a well-written plan and a well-written follow-up for both the children. So what other major advice would you give?
like
You have started on hydrocortisone. Have you started the baby on salt?
no, not yet.
Okay. It would preferably, salt can be added because usually the renal tubules in infancy are a bit resistant to aldosterone. But in your case, I think the baby is responding to a very small dose. Maybe you can decide on follow-up. Okay. So in a severe form of CH, salt-losing form of CH, which is presenting in the newborn period, I'm asking about such a case. How would what dose would you start hydrocortisone? What dose would you start fluorocortisone? What is the dose of salt? If you know the answer, you can mention. Otherwise, no worries.
Okay, hydrocortisone should be started at 15 to 15 microgram.
You
15
can mention
mg.
whatever it is. If it is wrong, we can correct it. That's it.
Uh,
15
the main
15?
15 mg per meter square hydrocortisone.
Okay, somewhat correct. But usually infants, especially with the severe CH, they would require a very high dose. They would require up to 20 to 25 milligram per meter square per day hydrocortisone. And later on in the later part of infancy, the requirement would come down a bit. And also fluorocortisone, they would require roughly around 50 to, some would require 150 microgram with added salt. So usually in the infancy, we would continue salt roughly around 2 grams salt to be
1 to 2
added in the
grams.
milk and later on in the complementary feeds, because the renal tubules are a bit resistant to your fludrocortisone. So providing salt would help to surpass the aldosterone resistance a bit. Okay. And again, I want to know about the major advice as a pediatrician you would like to give the mother. What will you write and give?
And like any, like during fever or any like any
Stress dosing, very, very
compensation,
important.
there should be stress dose should be given.
Exactly. Okay. How would you give the stress dose? Which
If it
drug would
was
you stress? Hike stress dose?
we should hike the hydrocortisone.
Yeah. How
If it
much
was a
would you
mild,
give?
if it was a mild, we should hike the hydrocortisone dose. Like,
You're very feeble. Your voice is feeble. What did you say?
ma'am, we should hike the hydrocortisone. We can.
How much? How much would you
How
hike?
much? Like
Somebody is
twice.
prompting you. You have to make it twice to thrice. Okay, so double or even triple the dose, especially if the baby has a high grade fever more than 100, loose stools, vomiting, any illness. Okay, so that should be written and given. This hydrocortisone should be tripled in severe illness for 2 to 3 days till the baby recovers. And suppose if the baby is not taking it orally, what would you do?
We can crush the tablet and mix with.
So baby is vomiting. The baby is vomiting out the hydrocortisone orally. What would you advise? So when you're discharging this baby, there should be proper written advices on the stress dose of hydrocortisone. Plus, you would ideally make the mother buy something. What is that? Buy an injection and keep it with them with a good expiry date. Which is that? Which injection? Again, hydrocortisone. Suppose the baby is not tolerating the oral tablet of hydrocortisone, the mother can take the baby to, suppose the baby is unresponsive, the mother is not sensible enough to understand the baby is deteriorating. She keeps on giving the oral tablet, thrice the dose, the baby is vomiting out. The baby is not responding. If they have the injection hydrocortisone, they can go, they might not be able to reach Kottayam Medical College easily. They might go to the nearby clinic and get a hydrocortisone IM, even if they are not getting an intravenous line, it can be given intramuscular, which could save the baby. So this is a life-saving measure. Every child discharging with CAH or any other forms of adrenal insufficiency being discharged should be ideally be taught to give an intramuscular injection of hydrocortisone. Okay, even one of our patients, mother herself, she's not a medical person also. Even before taking her to the, she had a seizure. It's a case of seizure disorder. So during the seizure, she was vomiting and she was not taking hydrocortisone. She was a case of a CH severe form. That is we call it as a lipoid CH, the star deficiency. Okay. Yeah. So 46XY-DSD read as a female. So the mother herself took the intramuscular hydrocortisone. It's very important to educate the mothers and make them buy a. So for every review, you need to see whether they have the hydrocortisone injection to be used at times of emergency. Okay. Okay, so that's it, right?
Like to weight gain, we can advise the mother on the other supplement and advice on.
And how would you monitor? How would you monitor this baby or baby S? How would you want to monitor this baby is on hydrocortisone, fludrocortisone, and salt, suppose. And so this baby, when will you call this baby is being discharged today? When would you want to call the baby and reassess?
The baby has
in your table to follow with serum electrolytes, 17-hydroxyprogesterone. So ideally, you would monitor testosterone and androstenedione also. 17-hydroxyprogesterone is usually done 3 to 4 monthly. And you can do testosterone along with that. Yes, and also as the baby grows, we need to monitor the weight, height, body mass index, because it's a very tightrope walk. You're giving steroids. You need to look at the growth. You need to look at the control of the disease. What is the problem if you're not controlling the disease? The testosterone is high. The baby is not going to adrenal crisis, okay? But suppose it is in a medium control, the testosterone is high and the baby is gaining height. What will happen? Venkatesh, do you want to think about that?
Like there will be advanced in maybe under treatment, advanced in bone age.
As I mentioned, it is a tightrope walk. We want to avoid under treatment and over treatment. Over treatment also would be causing issues. The baby, I mean, the child would be a bit obese and other issues. And under treatment also, basically, the testosterone would be high. There would be bone age advancement. What can bone age advancement cause in a CH? They can lead on to precocious puberty. Yes. So all these points need to be thought of while you're following up this baby further. Okay. Anything else you want to mention?
Like we should advise on the adherence to follow, because during the first child itself they had having
the timing of the medicines, the intramus, I mean the parenteral hydrocortisone administration, getting all the vaccinations done. All these are very important in this baby, right? So, yes. Anything else your co-PGs or anybody wants to add on? Okay, so if you can stop sharing, can I share a few slides?
Yes.
Your presentation is done, right?
Yes, ma'am. I'm done with the presentation.
Give me 2 minutes. Can you make me the host, Dr. Thomas?
Madam, you are the host. You can share now. Ma'am, you are the host now. Can you share, ma'am, right now?
Yeah, give me 1 minute. I'm trying to share.
Okay, ma'am.
You can see my slides, right?
Yeah, ma'am.
Yeah. Okay.
Can you make it full screen?
Yeah.
It is not. I can try it.
Okay.
Okay, ma'am.
A few slides. I just want all postgraduates. You can take a screenshot or this. This is a. I think it's the most simplified slide of the steroidogenesis pathway. This is very important. It's due to the time limitation, I won't be able to explain in detail, but definitely this is a self-explanatory slide. But you need to go through this. Usually, it is asked for your theory and also for understanding the basic pathophysiology in the different forms of congenital adrenal hyperplasia. It is very important to understand this pathway. Yeah. So this was the STAR deficiency, which I was mentioning. So STAR deficiency means the proximal pathway is blocked. So we know that this limb is the aldosterone pathway, this limb is the cortisol pathway, and this is a sex steroid pathway. So when there is a STAR deficiency, suppose it is a male baby with STAR deficiency, what happens is that these 3 limbs are blocked. So the baby will be having cortisol deficiency, aldosterone deficiency, and also sex steroid deficiency. Usually the XY baby would be having a female appearance, would be reared as a female, would present in adrenal crisis, will have severe, this is a severe form. The most severe form of CH would be STAR deficiency, which is otherwise called as a lipoid congenital adrenal hyperplasia. Okay. So, and then you have the 21 hydroxylase, which is more common, and also the not so rare conditions, 11 beta hydroxylase, 17, and also 3 beta HST. So please take a note of this table. This is very important to understand the physiology. So I thought we had last year, I think in 2 consecutive months, we had 2 infants with dyslipidemia. So our PG Dr. Raumisha's presentation, I've just taken it there. So this was a 2-month-old male baby who came with poor weight gain and cloudy urine, which I was mentioning, and frequent vomiting, just like your baby. So it's the presentations would be similar. And on history taking, the mother said the antenatal ultrasound had some abnormal fluid collection in kidney. The details, further details were not available. The baby had failure to thrive, a mild dehydration. The systemic examination was normal. So this was the second case who came in the almost same period, 1.5-month-old, again male baby, who was referred just because of an abnormal newborn screening report. They had poor weight gain and vomiting. Antenatal ultrasound, minimal oligohydramnios. This baby also had failure to thrive, a bit of hyperpigmented genitalia and a nipple. Systemic examination was normal. So again, these 2 babies had similar electrolyte pictures. So this is how you differentiate. I thought of showing this so that you get more idea on how to differentiate this and to be aware of these conditions. So the other preliminary investigations were okay. Sodium in the first baby who presented with fever, vomiting was very low, 117, and potassium was 7. There was acidosis. Same picture in the other case. Potassium was 5.6. Sodium was 118. And the other investigations were fairly normal. So when you have such 2 infants coming to your ICU or in the casualty, the history taking and the further investigations would definitely help us. So in the first case, we were almost sure that this baby had a cloudy urine. The urine showed numerous pustules. We had already sent the baby, the urine for culture. So in the first baby, we had initially suspected a transient pseudo-hypoaldosteronism. And with that in mind, we had sent a renin and aldosterone, which were very high. You can look here. The renin was more than 50,000 and the aldosterone was also very high. So the aldo and renin are high. That shows a aldosterone resistance. Okay. And you can look at the 17-hydroxyprogesterone, ACTH. So usually these will be high for the common varieties of CH, which were normal. So with a setting of UTI and hyponatremia, hypokalemia, it is more likely to be a pseudo-hypo. So we kept the baby in the ICU. We did not start hydrocortisone, treated the UTI, and in 2 to 3 days, the electrolytes normalized without any intervention. But the intervention was that it was a treatment for UTI. Whereas a second baby who came with an abnormal screening report, yeah, you can see the 17-OHP was high. Also, you can see the testosterone is high. And the serum cortisol was low with a very high ACTH. So biochemical investigations with a good backup of a good clinical history help you in diagnosing the proper, the etiology. So pseudo-hypoaldosteronism, I just want to make you aware, the postgraduates. So it could be a systemic. I'm not sure if you have seen a case of systemic PHA. It's a very, very difficult to treat condition. Many of the kids, if you look at the case reports of a systemic or a permanent pseudo-hypo, it's a genetic form of PHA. They usually succumb to illness. And transient PHA is the one which I was mentioning, usually associated with infection. So transient PHA usually responds very well. Once you treat the infection, it reverts. Okay. So usually there will be an underlying urinary tract malformation. So that is also, which I forgot to mention. This baby had a urinary tract malformation and has undergone, is under surgical follow-up. So because of the aldosterone resistance, so when you have a urinary tract infection, because of the inflammatory mediators related to the infection, which cause a renal tubular resistance, and have a similar picture just like of congenital adrenal hyperplasia. Okay, so you can have non-specific symptoms, failure to thrive, dehydration, vomiting, life-threatening salt loss. So if you have this in mind, it's very important. So these were the DDs which I was mentioning. When you have a infant coming with features, overlapping features where an adrenal etiology should be thought of, these could be the DD. You should think of a neonatal sepsis or meningitis in your case, an acute gastroenteritis or a surgical illness, pyloric stenosis, but look at the electrolyte abnormalities. Congenital adrenal hyperplasia, the most important one, which should be identified appropriately and treated without delay. Even if it is a pseudo hypoaldosteronism, if you don't have facilities to biochemically diagnose it, you can err by giving hydrocortisone and fludrocortisone, and probably when later on if the baby does not respond to that, maybe you can think of review the diagnosis, and because CAH is very important to be treated without delay. And also congenital adrenal hypoplasia, another important cause of adrenal insufficiency. It is different from hyperplasia, the pathology. The hypoaldosteronism due to aldosterone synthase deficiency, which I was mentioning, and the pseudo hypoaldosteronism PHA, which we have discussed. Okay. Yeah. So, zoom in. Stop share. I think if you have any questions, we can take up, or what do you say, Thomas? Or if you want me to quickly run through 1 or 2 cases of ambiguous genitalia, I can do that. Or if you want me to wind up, yes. Any questions, postgraduates? Am I audible?
You are audible. Nothing is coming.
Treatment of pseudo hypoaldosteronism, Devi has asked. So basically, for transient pseudo hypoaldosteronism, it is treating the UTI or the obstruction. So usually simple UTIs does not produce, they do not usually present with pseudo hypoaldosteronism. So there will usually be a malformation. Proper surgical management is also needed. And if you are asked about systemic PHA does not respond to anything. It responds only to very high doses of salt. And also, even with high doses of salt, it's a very challenging situation to manage, especially during illness when these babies or older children might not tolerate the salt. We have had a lot of issues, but still managing, if the families are counseled properly, can be managed. Yeah. Madam, anything to add on?
Thing actually, just a good presentation and also a good discussion.
Yeah, good presentation, Dr. Venkateshwar. Dr. Thomas?
Ma'am, there is enough time to discuss few more clinical scenarios.
Just quickly, it's not an elaborate. Last month we had a panel.
We can go up to 9, no, madam. Yeah. We can go up to 9.
Take 20 minutes. We had a discussion on ambiguous genitalia. I'll quickly show the cases so that the postgraduates can have it. It's not a theoretical discussion. It's just a...
Okay.
Yeah, as too much. Are my slides visible?
Yeah, ma'am, it's visible.
Okay. For the postgraduates, this is the present classification of DSD. You can just take a note. It is available in all standard textbooks. 46X6 DSD. So your CH, majority of your salt-losing CH comes in the 46X6 DSD. And also the 46XY DSD and sex chromosome DSD. So I'll just quickly, I think the second case should be put first. I'll go to that first. Yeah, so this is a classical garden variety of CH. Venkatesh presented a male baby with the scenario, which is more common and easy to diagnose. Male baby with CH, as I told, it is very difficult to diagnose. It might mimic or it might land up in other places, probably thinking it's a meningitis or sepsis or gastroenteritis. So, but this is a straightforward diagnosis. This is a 17-day-old newborn with vomiting, poor feeding, lethargy for 3 days. First baby of a consanguineous marriage. Birth weight was 2.8 kg with I think the hyperpigmentation is so evident here. Present weight is 2.5 kg with failure to thrive. So the baby on presentation had atypical genitalia, no palpable gonads. Okay. So when you have such a phallic-like structure with hyperpigmentation, no palpable gonads, the first thing that you first differential diagnosis that should come to your mind is probably congenital adrenal hyperplasia 46XX DSD, which should be supported by your other investigations, biochemical investigations, as well as sonological investigations. So you can see the fused labioscrotal folds, and there's a single perineal opening, which suggests the virilization. Okay. So the phallic length is quite high, 2.5 into 0.6 centimeters. So this baby had a biochemical investigations. You can see sodium is low and the potassium is 9.9, a negative sepsis screening. 17-OHP was diluted. The value was 584. Karyotype was 46XX. Meanwhile, we could get an ultrasound. Getting an ultrasound in a newborn is we need experienced sonologist because it's very difficult to identify the uterus and ovaries. Sometimes you might get no ovary, no uterus, which is again going to complicate the issue. So uterus and ovaries were visualized here. So our clinical diagnosis is congenital adrenal hyperplasia in salt wasting crisis. 46XX, the most common variety of DSD. Okay. So you can see, as I mentioned, the imaging is very important. It's an observer-dependent condition. So experienced sonologists need to be looking at this. Okay. And also genitoscopy, the role, there is no hurry in this baby because we mentioned there is probably a urogenital sinus, a single opening. To look at the confluence of vagina to urethra and plan later surgery. So as we know, I'm sure all of you are aware of the new Kerala High Court guidelines regarding surgery in DSD. There is no hurry. Actually, you can wait till the family is counseled and the multidisciplinary team agrees. So the Chennai High Court and Kerala High Court has provided guidelines for that. So the immediate management in this newborn would definitely be hydrocortisone. So the hydrocortisone standard dose is 10 to 15 milligram per meter square in 3 divided doses. But usually infants would require a much higher dose, 20 to 25 milligram per meter square for proper control. Later on in infancy, it would come down to 10 to 15. And fludrocortisone, the dosage is 0.05 to 0.2 milligram per day. And salt supplementation is essential because the reason I've already mentioned. And stress dosing should be should be explained in detail. And for postgraduates, looking at the genitalia, you have to give so especially if you have a virilized female, you need to look at a scoring called Prader staging. And also there is a external genitalia scoring, which is actually a gender neutral scoring, which can be used and where this phallic structure is referred to as a genital tubercle. I think you can go through that external genitalia scoring. This Prader's is for the virilization score. Okay. So surgical management in CH46X. So you can look at this. This is the same baby. This is the initial presentation and this is on follow-up with hydrocortisone and fludricort. Okay. So this baby later on might require a surgery for the urogenital sinus that can actually, as I mentioned, based on the recent High Court order, you can wait and later decide after discussing with family, the multidisciplinary team can decide. Okay. So you need an approval from a state level multidisciplinary team for sex selective surgeries. The committee should include multiple specialists. Okay. So the second case, I think postgraduates can give the differential diagnosis. So this is a term baby born at 37 weeks. Birth weight was 2.75 kg. The baby was noted to have micropenis. The stretch penile length was only 1.1 centimeter. Bilateral testis was palpable, a bit high in the scrotum, a small scrotum. The baby was admitted in an ICU for respiratory distress, had hypoglycemia. At 1 hour age, IV fluid was started on feeds and IV fluid stopped. Again, GRBS dropped to 45. So this is a baby, term baby with micropenis, hypoglycemia. So in such a baby, how will you plan the investigation? So when you have a persistent hypoglycemia, usually you would want to do a critical sample. So critical sample was done. And you can see the cortisol was 0.6, which is low. So usually when there is hypoglycemia, we expect a high cortisol. And also a TFT, you can see the free T4 is low. So this is again suggestive of when the free T4 is low, but the TSH is normal, or an inappropriately normal TSH for a low free T4. That is suggestive of a central hypothyroidism. Okay. So because there was low cortisol micropenis, we were thinking more in favor of a central cause. And also, we need to understand there's a condition called mini puberty, which usually starts by 2 weeks of age to 6 months. At that time, if you check the pubertal hormones, it is likely to be in the pubertal range. But for this baby, all the hormones, pubertal hormones were low. Again, confirming the hypopituitarism. The cortisol is low. There is central hypothyroidism, hypogonadism, and ACTH stimulation. There was a poor response. So in this baby who has a micropenis with hypoglycemia, multiple pituitary hormone deficiency is more likely diagnosis. Okay. So in a newborn, it's very difficult to identify hypopituitarism. They may present with multiple overlapping symptoms, which might be a symptom of neonatal sepsis, meningitis, or other infections in the newborn. They could have poor feeding. So these pituitary hormone deficiencies could have jitteriness, lethargy, seizures. So it's important to think of pituitary hormone deficiency if you have suggestive findings. So this baby underwent an MRI, and we found that this baby had an absent pituitary stalk. This is a normal pituitary image. You can see the stalk. Hope you can see the stalk. This is the anterior pituitary. This is the posterior pituitary. But here the stalk is missing. And also the anterior pituitary is hypoplastic and the posterior pituitary is a bit ectopic. So this is a classical pituitary stalk interruption syndrome. So this baby with micropenis and hypoglycemia had a multiple pituitary hormone deficiency as the cause. Okay. Yeah. So when you have a multiple pituitary hormone deficiency, the other MRI findings which you would look for are these. I'm sure you must have heard of septo-optic dysplasia or the Demoisius syndrome. So in such babies, usually we'll replace the multiple pituitary hormone deficiency. Just want to mention, when you're treating a multiple pituitary hormone deficiency, you would make the baby or the child cortisol sufficient first, and then later on add thyroxine. Because if you start all the hormones together, especially cortisol and thyroxine together, there is a chance that the baby can develop adrenal insufficiency, because thyroxine has a property of washing off whatever cortisol is available. So there's a chance that the baby can precipitate adrenal crisis. So usually 40 to 72 hours, you treat with hydrocortisone, then add thyroxine, and later on other hormones as at appropriate ages. Okay, so I just want to mention, this is a child, who presented last, I think around 2 months back. This is this baby, again, similar diagnosis. So I just wanted to mention it. This is an 11-year-old boy who came to the pediatric neurologist with lethargy, developmental delay, behavioral issues, hypertonia and all. There was a history of micropenis, delayed puberty, a newborn history of hypoglycemia. So an endocrine opinion was asked for, and also has a short stature. So the preliminary investigations was sent, and again, similar biochemical picture. Here you can see the free T4 is low. If you look at the TSH, it is normal. A 4.8 TSH alone, if you're given, the value is normal, but it's very important to correlate it with the free T4. Here, the free T4 is low. For this free T4, we expect a high TSH. It is not there. This is called a inappropriately normal TSH. This is classical of a central hypothyroidism. And the cortisol is low, the ACTH is low. Again, same. When the cortisol is below 1, we expect the ACTH to be high. It is not seen. That is because the pituitary is at fault. And also all the the FSH, LH, testo, they were low. And IGF-1 is low. So this is again a classical multiple pituitary hormone deficiency. The first one was being diagnosed in the newborn period, and this child is being diagnosed in the adolescent period. Okay, again, this adolescent had an MRI, had a same pituitary stalk interruption syndrome. So he has been started on hydrocortisone and thyroxine, and this week he has come for starting growth hormone therapy. Okay. So this case I had already mentioned. I think we'll stop with that. Too much of cases would be boring for the postgraduate. So I think you should go and read about congenital adrenal hyperplasia and the different causes. For example, 21 hydroxylase, 11, 17. and read about the differential diagnosis. So for practical purposes, when you have such a baby presenting, especially a male baby, please think about the differential diagnosis. And as I mentioned, the first most important DD to be ruled out is definitely congenital adrenal hyperplasia because of the grave prognosis if it is not treated. Okay, and also you need to be aware that CH can present in, the severity, it is a huge spectrum. It can present with different, you know that there is late onset CH where boys could present with peripheral precocity, or even girls could present with PCOS. So there are different varieties of presentation of CH. So the most, around 90%, it is because of your 21 hydroxylase, which could be easily identified, especially if it's a female baby. So the newborn screening has come a big way. Now we've started getting referral just because the newborn screening is high. There are chances of false positive screening, which you have to confirm with probably an LCMS or a repeat values, and look at the clinical history, follow up the baby and decide. Okay. So thank you all. Any questions I would try to answer. I think the chat box has questions or comments.
Chat box basically comments. Treatment of pseudo parnano.
Regarding the presentation, Dr. Venkateswaran has done well. A few suggestions are, since there is a similarly affected sibling, he could have mentioned few more details about that child. What are the symptoms and how that child is being managed now, or whether that child is having frequent problems and all. And that is one thing. And another thing is, as I mentioned in the chat box, whether child underwent child had neonatal screening. And another thing is a little more mention about the skin pigmentation, especially the color of the nipple, color of the scrotum and all. So that should be highlighted. These are the few things which I thought is important.
Thank you, sir. Very true. I think from next presentation onwards, Venkateshan can take care of such things. And after the history, there should be a proper differential diagnosis, which should include much wider areas of diagnosis. And then you narrow down your diagnosis based on your clinical examination and your investigation. So that is how you approach each and every case in pediatrics. Sushma, madam.
Leave ചെയ്തെന്ന്
Okay.
കാണുന്നില്ല.
Antenatal diagnosis was suggested. Probably they were not on correct follow-up. It was not suggested possibly. Ideally, it should be counseling should be given, the genetic diagnosis, and the I think Mohandasa would be able to explain it further. Should have been done. Yeah.
Madam Parvati, madam, actually they were advised to take this checkup when they were found to be pregnant, but they were not willing for that.
Actually,
okay. And they were not coming for proper follow-up also as per history.
No, actually they were in Middle East.
Okay.
So they came back only when she noticed that she was pregnant this time. And
Okay.
she was shown to the local hospital, and they were advised to do a checkup at Ernakulam, but
Yeah.
they were not willing. That's why they were hesitant to, because they were advised to take drugs if they found to be to prevent this. We gave dexamethasone, madam. So they were very hesitant for that.
Is it
Dexamethasone
advised
treatment
actually
is a lot
this
of
dexamethasone
Yeah.
to reduce the size, the titeromegaly?
Yeah.
Is
So
it now
she
advised?
maybe
No, actually, sir, it is not. It is a big controversy. We need a lot of ethical clearance to give that, because the evidences are not, it is given to reduce the virilization, but the side effects of dexamethasone,
Yes.
side effects in baby and mother, lot of issues. We need to get lot of ethical clearance to give that. So
Okay.
there is a lot of confusions on that. But I think many of the families, they go in the same route. When you say a genetic diagnosis or counseling, it's very difficult to convince them. So probably that's the reason they also just,
Prenatal diagnosis also, because it being a treatable condition,
yeah,
there are ethical aspects.
exactly, yeah.
Okay, madam.
I think.
Okay, thank you, Dr. Gigi.
Thank you,
Darling madam, any comments? Can we wind up or?
Definitely, we can. It was an excellent session from the discussion, and also Mingi has presented it well.
Yes,
Okay.
yes, definitely.
Definitely.
Okay. Good night.
Thank you,
Okay.
madam.
Thank you. Thank you all. Thank you, Dr.
Good
Thomas.
night. Thank you. Thank you. Thank you.
Yes, sir.